Okay, so we have a very unique privilege of having one of our friends and colleague, Dr. Amer Johri. Dr. Amer Johri is a clinician scientist at Kingston General Health Science Center of Queen's University. He's a full professor at Queen's University. He's also the founder and director of the Cardiovascular Imaging Network at Queen's, as well as the POCUS journal that is online. He has many other accomplishments, including a very nice POCUS series that was actually hosted and sponsored by American Society of Echo, and also our treasurer at Canadian Society of Echo. And as I mentioned before we start, if I keep going on his resume, it'll take another hours or so. So we're going to abridge it. And Dr. Johri has put together a very useful scanning training program, particularly for hypertrophic cardiomyopathy. One of our challenge of doing these kind of cases is actually figuring out how to optimize the gradient, and that's always highly variable. Doing Valsalver and how to make it reproducible has always been a challenge because we're managing our patients with their symptoms and gradients, and the gradients tend to be one of the most variable factor in what we do. So that's why specifically I invited Emma a number of months ago, trying to come and actually share with us, and also we'll share with the online participants, as well as we'll have a version of it on our St. Michael's Virtual Echo Rounds YouTube website. So then, if we need to come back to it, then we'll have it. So without further ado, I'm going to pass it to Dr. Johri. So
great.
Thank you.
Thank you so much, Shimeng. It's wonderful to be here, and I'm very excited about delivering this program. And the reason why I took names is because I want some interaction during the talk. So please speak up, and I might ask you some questions more about what your opinion is. There's no right or wrong answers. And we'll move forward from there. So just to mention that we put this program together, there's a number of people that helped us, including Kibar, who's in Toronto, as well as Anna Wu. And we're hoping to continuing to update this program. These are my disclosures. And the program is accredited by Sonography Canada and endorsed by the Canadian Society of Echocardiography. So the goals today are to learn about acquiring and interpreting echo features for HCM as well as HOCM, and identifying echo features used to guide novel therapy. So this program we've delivered by the end of the year, sort of 34 or 35 or so echo labs across Canada, actually. And it's sort of like a pick your own adventure. We have different modules, and Chiming was thinking module A and C is good. And then at some future point, we can come back to module B. And then we have a number of cases, and we're going to talk about case 2 today. And there's lots of time for questions. So I'm going to just get started with our pre-activity assessment. This is just to prime your brain. MR caused by LVOT obstruction from SAM results in a jet that is A, anteriorly directed and predominantly mid to late, B, anteriorly directed and predominantly early systolic, C, posteriorly directed and mid to late, or D, posteriorly directed and predominantly early systolic. So should we launch that? I don't know if people are going to try to do that online or offline. Yeah, we've got
there are people coming in, yes.
Okay. And you let me know when you want to move on to the next question.
Okay, so, yep. So please do sign in and then respond to the poll if you're on your phone or your computer. Okay, they're coming in.
It's mostly the online people that can sort of fill this in, right? Yeah.
Yeah.
Okay.
Mostly number 3.
Okay. Good. All right. So I'm going to end the poll there. We've got some other answers there as well. That's good. share results. Do I need to share the result?
No, it's okay.
Okay.
Because we have all 4 questions in the same poll.
All right. And
Keep
then
going.
can we get rid of the poll there? Let me see. So I'm going to move the poll out of the way there so I can read. Okay. Which of the following statements is false? Obstruction is present or develops in most HCM patients. MR velocity is higher. MVO or mid-ventricular obstruction is in 10% of patients. MVO is dagger shaped. So do we want to do a poll there?
Yep, the poll is still open. So now it's not question number 2. There you go. So far the 4th answer is leading. Please continue to enter your answer. Okay, so still the 4th question. So you have to scroll down on your poll. So there's a poll, the same poll has 4 questions.
And we just have 2 questions and then we'll move on.
Okay.
Okay, good. So I'm going to close this there. Okay, and then I'm going to get started. So in the spirit of traditional grand rounds where we would have a patient, this is the patient
Well, I do know that
today.
I was diagnosed with 10 years ago now, so I've been dealing with it for about 10 years. I know that is a genetic condition, and my father had it, my grandmother had it, of course myself, and then my youngest daughter also has it. I do know that up until recently, I haven't been very symptomatic, but recently have had some changes, and it's that's about it, I guess.
Great, yeah. So tell me about the symptoms that you've been having and how they've changed over the last little while.
I've noticed that I'm more symptomatic with exercise and exertion. I'm noticing some chest pains and shortness of breath when I'm doing mild exertion, like walking up a hill or walking a little bit faster. Bending was becoming a little bit more difficult for me. I just felt like there's a lot more pressure in my chest than I was typically used to. And fatigue also was becoming a bit more of a problem for me. Yeah.
Tell me about your experience with the Echo Lab and why you think doing an echocardiogram is important for your condition. So what is your understanding?
Well, my understanding is it gives a very, clear picture of what the obstruction is looking like, what's happening with that, whether any changes have been happening over time. And I think for myself, it's allowed me to see what's going on with respect to medication and trying new medications and giving cardiologists the opportunity to see what's happening, what's changing, and therefore assessing it from that point.
All right. So I just wanted to show the patient's perspective there. It's called A Patient's Journey, this program, and really highlights some of the themes that emerge in these types of patients. So it's a familial disorder. They may have other family members. Their symptoms are quite vague. Sometimes it's hard for them to quantify or describe their symptoms. She mentioned chest pain, a bit of shortness of breath, maybe walking up the hill, fatigue. And we use the NYHA classification sometimes, and I'm going to talk a little bit about that. But the other thing I noticed is that most patients have a very positive relationship with the Echo Lab. And what's very important is that in this new era, that relationship has become vital and very important, because with a new pharmacologic therapy, it's highly echo dependent for diagnosis and monitoring. And so that's why we decided to develop this program. And so it's really important to go through some of the basic stuff and then talk about monitoring in terms of novel pharmacologic therapy. So I'm going to start with some basics, and I know I'm sort of speaking to multiple audiences here. And the sonographers are usually very good at giving us some nice measurements. They're making sure that their measurements are orthogonal to the axis of the left ventricle. And they're very good at making sure that they're not measuring trabeculations, both in the left ventricle and the right ventricle. They're making sure that they're not incorporating papillary muscles in their measurements. And they're also thinking about whether the septum is sigmoid or not, and is the measurement going to be variable depending on where you measure that sigmoid aspect of that. The other thing that's important to think about is whether you can acquire LV mass in these patients as well. Some labs report LV mass index, some labs don't. Does your lab here have this commonly reported? Yeah. It's important to remember that it does not necessarily correlate to hypertrophic cardiomyopathy, though. So here, for example, these patients with a lower LV mass index still had hypertrophic cardiomyopathy. And in fact, females with HCM seem to have lower LV mass indices, but important to measure. And then the other thing to remember to measure is not only looking at it from the parasternal long axis, but taking time to look at it from all aspects of the left ventricle, including the short axis, and checking your measurements there. So usually the measurements are reported from the parasternal long axis, but we kind of correlate them with our short axis measurements as well. So this is an example of significant hypertrophy greater than 15 millimeters. And what's really important here is that you want to make sure that you're avoiding sort of being off axis and being oblique, because then what you might do is also unintentionally overestimate the extent of hypertrophy as well. So it's very important that you're orthogonal in these different views. And then another thing we're going to focus in on is really looking in at the base of the left ventricle, because this is where you're going to get systolic anterior motion of the anterior mitral leaflet. So this is why we're focusing it here. And what we're seeing is pulling of structures related to the anterior mitral leaflet into the left ventricular outflow tract. So just want you to calibrate your eyeballs there, because this is a nice example of SAM. And we're going to have more examples. Some people use M mode as well. M mode can be helpful to visualize LV structures, but it's going to be very focused, as you know, along one line of the left ventricle. So we don't use this too much in our lab for measurements, but it is a nice thing that you can check as well if you're comfortable with M mode. One of the modalities that's a nice complement is MR. We're not going to talk too much about MR, but it has the greater accuracy of measurements, and it's able to identify different phenotypes. And then, of course, the tissue characterization aspect of MRI is really important. So here's an example of gadolinium enhancement showing myocardial fibrosis. So this is a nice example of extensive myocardial fibrosis enhanced in the apex of the left ventricle. Nice thick left ventricle here as well. So the next aspect is very important, and the American Society of Echocardiography has this wonderful guideline. You may have this poster up. If not, you can get this through the American Society of Echo. And they talk about different aspects of echocardiographic assessment of HCM, including recognizing whether you have a sigmoid septum, a reverse curve type of hypertrophy, as well as the apical form of hypertrophy. And remember, measurements greater than 30 millimeter are red flags for sudden cardiac arrest and sudden cardiac death. So that's why these measurements are really important. Now, this is very important. So we look for apical aneurysm in hypertrophic cardiomyopathy. And the reason why we want to do this is because it's a risk factor for sudden cardiac arrest. And one of the things that you can do to look for this is the use of contrast. So just going to chat with some of our colleagues here. So Tatiana, can you tell me how often do you use contrast for hypertrophic cardiomyopathy here? Is that something that you think of doing regularly, or? Yeah. Okay, great. And so that shows you the aneurysm. Sometimes it also might help you differentiate things like non-compaction as well. I've seen that, the contrast being helpful for that. And do you guys make the decision yourselves as sonographers to give contrast, or do you check in with somebody? Yeah, great, yeah. So the obstruction has different components, including related to mitral regurgitation, high intracavitary pressures, and abnormal mitral leaflet structure and malposition. They all contribute to the outflow tract obstruction. Remember, mid-ventricular obstruction is present in 10% of patients with HCM, and it can occur in ventricles with hyperdynamic function or concentric hypertrophy. So let's talk a little bit about obstruction. So this always confused me because there's two values floating around. The AHA recommends provocative testing if your outflow tract gradient is less than 50 millimeters. But then, you know, the textbook definition of obstructive hypertrophic cardiomyopathy is 30 millimeters. So I'm just going to talk to some of our echo fellows, I guess. So Michael, Rudy, how familiar are you with defining obstruction? Are you more familiar with the 50 or 30? What have you guys heard mostly?
So I've used the insert like obstruction.
Yeah. Yeah.
Is tied off therapy.
Very good. Yeah. 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 Great.
Yeah.
Mm. Yeah.
I think that I don't know if I thought a gradient that was 25, I would say there's no gradient. I thought it was.
That's right. Yeah. Yeah.
So,
Yeah. So if you do have a gradient of 25, what is the next step you wanna do?
start with bridge. That's like
Perfect. Yeah. 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 Great. So Grace, why don't you tell us, can you remind us how you provoke a gradient for a patient? Yeah.
We usually do the Solomon here now.
Right. Yeah.
I give instruction to the patient, such as with a small breath in and push down, like you're having a bowel movement.
Yeah.
I think that's the easiest way for the patient to relate to how I want the patient to, because
Right. Great. So just to repeat that for people online, Grace is mentioning she's asking patients to bear down and like they're having a bowel movement. Are those the instructions, Matthew and Aaron, similar instructions that you give? Yeah. What do you tell them about their breathing or anything? Do you help them with that? Yeah, go ahead.
They bear down, like they have to hold it down, push as long as they can until get the good dagger shape.
Yeah.
If there is anything that they show.
Mm-hmm. Yeah, requires some coaching. I notice that patients also take a deep breath in as well, or they're changing their breathing, and that's also having additional physiologic effects. So sometimes I try to say, bear down, but try not to change your breathing if you can, because that can increase right-sided pressures and have its own effects as well. So it's interesting. Okay, so that's great. So it's really important to think about provoking the LVOT gradient. So for example, if it's 25, another thing you can do in terms of provocation is looking at stress echocardiography as well, and seeing if the gradient is higher during an exercise echocardiogram, for example. So let's talk a little bit about this further. And this is the tricky part. What we don't want to do is mix up our mitral regurgitation with our outflow tract gradient. And that is a common pitfall. I've seen it happen many times, and we're giving the wrong values, assigning the wrong values to our patients. So, Michelle, what are your initial thoughts on differentiating MR from outflow tract obstruction? And then we'll go through this a little bit further. Yeah.
Honestly, first of all, the basics, just make sure that my CW is in the right stop spot.
Right.
Then just from looking at the tracings, I think probably look for if there's like some sort of elevated obstruction that mid-systolic shape that's usually keeping in the aortic area.
Great.
And the MR is usually meant to end system from what I would call.
Yeah.
That's
Okay. Yeah, that's great. So exactly as Michelle is mentioning, he's thinking about where the cursor is placed, and he's thinking about the profile shape as well. And so the MR is a wider profile. So here's an example of the mitral regurgitation. It's a wider profile. And Michelle mentioned that the shape is different. So the LVOT is usually a little bit more of a sharper profile. So it's more of a dagger shape here as well. And then what you have to remember is sometimes there can also be a mid-ventricular obstruction. So you can get sort of 1, 2, 3 profiles. And so you not only have to differentiate your outflow tract obstruction from the MR, but also from the mid-ventricular obstruction, right? So quite an interesting nuance there. The other thing Michelle was getting at is that your MR velocity will also be higher as well. And we'll talk about some different examples. So that shape is really important. We have a nice case that will demonstrate this as well later in the presentation. Now you can get the outflow tract gradient from the peak MR velocity. So you can get your LV pressure using the Bernoulli equation, and then subtract your systolic blood pressure, and that gives you your outflow tract gradient. We don't typically do that in our lab because there are some assumptions here, like your LA pressure. So we usually just try to get it from that. Do you guys do this in your lab? Do you try to calculate that, or it's something you could do as a quick check to correlate? Yeah. I think it's not necessary if you have a good profile. So some pitfalls to remember. You want a direct beam across the LVOT. Look for that dagger shape. And the MR has an earlier onset. It's higher peak. And you want to move that transducer away from the MR jet. So we'll talk about that. So let's talk a little bit about MR. This is Dr. Patrick Garceau's contribution. He loves looking at SAM and MR. And it's due to a failure of coaptation related to the posterior mitral valve leaflet. So the MR is usually mid to late systole. And the gap is determined by how mobile that posterior leaflet is. But it's that anterior leaflet that is being sucked towards the septum, and so you're getting that malcoaptation. And so your jet would be posteriorly directed, right, when it's related to SAM. Does that make sense? And if it's not posteriorly directed, we'll show other examples, then you're thinking that maybe it's not the SAM, maybe there's other causes of mitral regurgitation there as well. So we'll show you some examples of that. Again, this is a nice example. I'm just, trying to calibrate your eyeballs by showing you many different examples. This short mid-cavitary gradient, this is the outflow tract gradient. You can't see the cursor, but it's in a better spot. And this is the MR, right? So it's sort of a wider jet that goes further down. More examples, you can see systolic anterior motion. So it's not necessarily the proximal portion of the leaflet. It could be more the tip and sort of the chordal part that's being sucked into the outflow tract that's causing the SAM. And here you can see the MR jet. It's going towards the posterior here. Look at this particular example. I think you can see that the tip of the mitral leaflet is kind of curving into the outflow tract. Would you guys agree with that? And so again, that's leading to lack of coaptation and the posterior mitral regurgitation. So we really want you to work on recognizing that and calling that. Yeah.
It's sometimes differentiate the leaflets from the floors because they're
Yes.
structures. Conundrums.
Yeah. Here, do you think, Mike, is it more cord or leaflet tip, would you say?
Certainly there's forward.
Mm-hmm.
Question is there's some if there's it's really regular MR jet, then I would say there's some component that is.
Yeah.
But also it's redundant. Yeah, right. So that also a challenge to differentiate.
I agree with that. Yeah.
If there's obstruction.
Right. Yeah. And the other thing that could be happening is that your papillary muscles may also be more anteriorly displaced. So you can see that here and here as well. And certainly MR can be helpful in recognizing that as well. So this is just a reverse parasternal long axis, and this is the outflow tract here. And we can see that there's some papillary muscle displacement as well. Really depends upon how much slack there is in the chordal structure as well, and that can vary from patient to patient.
Or something like that is really difficult.
Mm-hmm. Yeah. Yeah, this is an example of particularly thick chords here. Yeah, and we got a great view. So, but you remember, you can have other things happening, right? So here's an example of a lot of calcification, and there's probably been some leaflet damage as well, probably fibrosis and thickening. And so that can also cause MR on its own, right? So trying to figure out whether there's SAM occurring or not is really important. The other thing you want to look for is, trying to differentiate the outflow tract obstruction before you do even the Doppler, you want to get an idea of, is there supposed to be a mid-ventricular cavity gradient? And you can look at whether the walls are collapsing. So here, the color is showing that probably there's going to be a mid-ventricular gradient, cavitary gradient. So you know that you're going to have trouble with a Doppler profile. So looking at that from the beginning here as well is an important step before trying to get your outflow tract obstruction gradient. These are just more examples of complex disease, and we don't have to go through all of them, but that can cause some issues with determining whether you have SAM or not. So here we have sort of two jets occurring. One of them is due to the calcification of the valve as well. This is a nice example, another nice example, posteriorly directed mitral regurg, SAM, as well as papillary muscle displacement in a nice thick left ventricle. Okay. So this poster just summarizes that, and we're gonna end this section here and ask if there are any questions. Just a quick summary: we're looking for wall thickness 15 millimeters or 13 if there's a family history. So that is helping us decide whether hypertrophic cardiomyopathy is present. That outflow tract gradient, if it's 30 or greater, we're starting to get worried about what we need to do next. And of course, we're provoking the patient to see if we get to that 30. The papillary muscles might be displaced as well. I won't get into too much into some of these angles today. So let's go back to our questions and see if things change. So MR outflow tract obstruction results in a jet that is A, B, or C.
You want the post?
Yeah.
Okay. So let's do the poll again. Post has control. There we go. Okay, please vote. There we go.
Okay. So this is a little bit tricky, I think. We're still getting wide distribution. The correct answer is C, which we're getting most of. So it's mid to late, and the early is more related to sort of complex MR. So it's the posteriorly directed, that's mid to late. It's not anteriorly directed, and it's not early, as we talked about in those examples. So I'm going to end the poll there, and we'll go to so the next result here. Which of the following statements is false? And so we'll do the poll there. Is that the answer? Is that the answer people getting?
Yeah, that's the new one.
Okay.
You want to start with the full answer, see the answers.
Yeah. So there was some controversy in the committee as to this question, because if you look at mid-cavitary gradient, it's kind of dagger-shaped looking as well. But it, what it's getting at is that the dagger shape, like classically, is the outflow tract obstruction that is dagger shaped. But the examples I showed you were of mid-ventricular obstruction, which were also dagger shaped. So, it's almost like I think this is a trick question in a sense. Yeah.
I was thinking of number one actually, because
Yeah.
you see a lot of patients with HCM,
Mhm.
and you haven't really in this case specified apical versus reverse curvature.
That's true. Yeah.
And A could be correct too,
A could be
because
correct.
it doesn't
Yeah.
occur in most.
Yeah.
In a whole bunch of them.
A could be false, is what you're saying.
Exactly.
Yeah.
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 It's like the board exam, so you can argue.
That's right. Yes, exactly. Okay, good. So we'll stop there just for some questions. So what do you guys think? Do you feel that we're doing a good job right now in terms of getting the distinguishing SAM and distinguishing the MR from the outflow tract obstruction? Is that a challenge? So, Aaron and Haney, what are your thoughts? Yeah.
Very strong hand.
Yeah.
Stabilize our dorsal alignment.
Mhm.
Second of all, I can speak for everybody else, but my routine is I will get a sample MR first with the gradient marked. So
Okay.
readers can see this is the gradient, and then I'll start to hunt for the LVOT, the highest gradient.
Mhm, mhm. Yeah.
It's, especially with the anterior direct MR. So the contamination of that MR can vary the actual LVOT.
Mhm. Yeah, that's great. You guys.
You can find that useful.
Mhm.
So the reader can have that what that profile looks like. Sometimes you get the UT, the CW, that's kind of mixed with MRs and
Mhm.
the separate.
Mhm. Mhm. Yeah. I think this, what I'm going to do is go right to our case actually, and then we will go to back to module C, because I really like the discussion and what Erin mentioned there in terms of how she does the hunting. So I'll give you an example of the hunting that occurred in this case. So this is Leanne. She's a 53-year-old lady with known obstructive HCM diagnosed 15 years ago. She's getting a little bit worse now. Her previous echo showed a gradient of 20, that's increased to 30 with Valsalva, and her path has been normal. She'd been tried on calcium channel blockers and beta blockers. So before we go towards the gradients, as the sonographers have mentioned, and really figuring out what's going on, what's going through your mind. Maybe I'll ask some of the C2s, Michael and Jamie. What do you guys? What's going through your mind when you see this this case presentation?
I mean, the most concerning feature is that her symptoms are getting worse.
Mm-hmm.
So, like from a clinical perspective, that would be my concern that maybe her disease is progressing.
Yeah.
Also, just like in terms of her like activities of daily life, function,
Mm-hmm.
obviously going from those symptoms just for NYHA to fix the big change.
Yeah.
Yeah, I'll just add, she was previously on beta blocker, calcium channel blocker, which was slowing her heart rate. And tolerated, but that could increase preload, which would split open the LVOT.
Great.
So hopefully we could try to titrate those medications.
Great responses. And so it would make sense to repeat our echo now, right? And take a look why she's getting worse. So let's do that. So these are her echo findings. And there's this is all basic. There's no trick questions. If you guys want to jump in, what do you guys? What's catching your eye here? It's a thick left ventricle, right?
Very like hypertrophic nasal septum.
Yep, very good. Amazing.
it looks like there's an MR, and there's some turbulent flow sort of in the LVOT system.
Perfect. Very good.
Apical image, there's real short access.
Mhm.
Walls look thick to me,
Excellent.
but the functions.
Perfect. Strain is maybe down a little bit, nothing too spectacular. So this was a challenging case for the sonographer, kind of similar to what Aaron was saying. And so here, this is exactly what the sonographer did. They really tried to show initially what the MR looks like. So they're going through the MR and they're getting this very high velocity of 6 meters per second, right? So they're establishing that first. And then they're playing around with a pulse wave. They're moved up back into the left ventricle, and they're putting back on their CW, and they're realizing at this angle they're still hitting some mitral regurgitation. So maybe they're not in the right spot here. And then they're trying to shift the CW line over more towards the left ventricular outflow tract. The velocity is a little bit lower, so maybe we're getting into the right angle now here, 3 meters per second. Here, what the sonographer is doing, we call it walking down the left ventricle, which is similar to what you said. You're hunting for that gradient through the outflow tract. And you were more angled towards the MR before, and you showed that it was 6. Now you're moving away from that angle and trying to get into the left ventricular outflow tract. You're walking down a little bit further. It seems to be not changing. You might be in the right angle there, so you're happier with that. Then you sort of keep walking towards the outflow tract gradient there. It's a little bit higher. That's probably the best angle here now, the highest velocity without MR contamination. So now you're sort of more around 4, and you're thinking that the outflow tract gradient is more around 4 meters per second at this point. This is probably too low. So basically what's happening is multiple angles and sort of multiple spots through the left ventricular outflow tract. And then once you're happy with the sort of 3 meters per second, not quite that 6, you're going to do Valsalva and note that it goes up to 3 to around 5, right? So that is showing you that you're in the right spot, and it's changing with Valsalva. So you can be fairly confident that's not the mitral regurgitation. So the point of me showing this with so many different Doppler profiles is to show how extensively and carefully you need to take different measurements. Aaron, would you have taken the same approach in this case? Yeah. Yeah, just walking it down. Yeah.
Does it help you to actually aim it more anteriorly where you see the aortic valve, or is it better to be the other way around, or do you actually have to experiment that back and forth? Rocking the probe.
Yeah.
We see the April 3 as well due to the
Yep. Yep. The apical 3 is great as well. So it might be different for different patients. It's really important that it's done the same way between patients. Sorry, for the same patient between studies. So it's really important to look back to see how it was done and how the previous sonographer walked through it and what angle, because it can have an impact on how medication is titrated. Yeah. So that's basically what we're trying to emphasize here. So using both pulse wave and CW to determine the Doppler profile. Initially, we were getting 2 to 3 meters per second. We saw that. We did, find what the MR was. That was 6. We put that aside. That's not what we want. And then once you have the MR, you're trying to angle away from that and get into the LVOT to get the peak LVOT, multiple acquisitions to get the highest one. And then you do multiple test Valsalva. So that's when it was going between 2 to 3, you were testing it. And then you do your final Valsalva to show the interpreter where you think the rest is and the Valsalva, and make sure it's labeled clearly for that patient. And then this patient went on to get some therapy, and in fact, their gradient did improve over time. So what I'm going to do, just for the sake of time, because we just have an hour, right? I'm going to quickly go to our therapy module and then end there. So why is echo important? HOCM, diagnosing, screening, risk stratification, and ongoing management. So as you know, for management with hypertrophic cardiomyopathy, we're looking at beta blockers, calcium channel blockers, disopyramide, but now there's these novel agents. So parameters that we're really interested in is the extent of LVH, the EF, and the gradient. And we're using that 30 millimeters to define obstruction. Remember, we talked about different values. This is, oh, sorry, yes, we can do that. Yeah, just so you can see that better. So this is key to understanding how echo helps guide novel treatment. So what we're talking about here in this particular case is mavacamten, which is a myosin inhibitor. If the EF is greater than 55%, you can start with 5 milligrams. And then you're providing an echocardiogram every 4 weeks for 3 months, then every 3 months for life. And what you're looking for are 2 really important things. The ejection fraction, is it above 50%? And what's happening to the outflow tract gradient. Even if the outflow tract gradient has gone down and it's almost gone, you still need to measure whatever you have, and you have to do Valsalva to see how high it's getting. So what I had to correct my sonographers because they were saying, oh, the patient's better, there's no gradient at rest, they would move on. But I was like, no, I want to see it at rest and at Valsalva still. And report it. And I had to correct my interpreters. You can't just say the gradient's gone. I want to know what the value is. Because if it's gone too far down, less than 20, then we actually have to titrate our medication down to 2.5 until it's back above 20, and then that's the maintenance dose. What we're trying to do is keep them on the lowest dose that they need. If it's sort of around that 20 range, then that's their maintenance phase, 5 milligrams. So any questions there, because that's really important in terms of the key for echocardiography. So you guys are, I'm assuming, regularly doing echoes for mavacamten now? They're coming through the lab? Yeah. Okay. And are you guys doing full echoes or limited echoes? What's been the approach?
Still full at this point.
Okay. Yeah. So you're reporting all the gradients with Valsalva and all that stuff. Yeah, great. And how is the workflow for that?
We've been fortunate to have enough slots, so we haven't been having major trouble at our institution to accommodate these increased numbers.
Right. And these numbers are going to keep increasing because the patients just accumulate, and then they're getting echoes for life. So they're going to, at least for now. Are there thoughts of moving towards a limited echo or keeping it full echo for now.
I think we're still fairly early in this particular venture. So
Yeah.
as we move along, those are the considerations.
Yeah.
To limit the studies.
Yeah.
Looking at EF and primarily LVOT obstruction, both at present with Valsalva. That
Okay.
could be the limited version in the future.
Yeah.
guys do that?
We're still doing full. We're exactly the same place. We're still doing full. Some places are doing limited as well.
Just like
Yeah. Yes, that's right. Yeah. There's been some thought of whether POCUS has a role, but as you can see, there's a lot of subtle nuances to get the gradient that I think the sonographers are best at doing. So I think, do we have some questions here? Why not do a Valsalva maneuver? Okay, sorry. When not to do a Valsalva? That's a good question. When would you not do a Valsalva?
If the gradient's already above 30, would you still do Valsalva?
I-
If the gradient's above 50, would
Yeah.
you still do Valsalva,
I would always do a Valsalva. Yeah.
regardless?
Yeah. Mm-hmm. Yeah, even you're right. They've reached the threshold. And so you have an answer, but I would still do the Valsalva to see how much it's increasing. Yeah. Sure.
Their gradients very high.
That's an amazing question. I don't think so. I've never seen that. Unless they're passing out when they cough or when they go to the bathroom. So if they have like, micturition syncope, and they're already doing that in their daily life, because the Valsalva isn't too much different than
Right.
what you might do. But that's a great point. Yeah.
I just like
Yeah. No, it's good.
I just want to ask one question, because that's the question I always have trouble with. We kept talking about Valsalva maneuver, but the problem is Valsalva maneuver can come in all kinds of grades, especially when looking at the stringing phase as opposed to be
The four phases. Yeah.
the other relaxing phases. So how do you actually, in your lab, how do you actually maintain the consistency that you're doing the Valsalva with a similar effort over time?
It's just about education and sort of going over it with each of the sonographers and our sonography students and then the new sonographers coming through. There's no way to quantify that the Valsalva has been done correctly. So I think that's why we're trying to have more discussion around it. But I can't think of a way to make it more standardized, which is what you're saying. Yeah. So for the calculation of the LV mass index, should we use the thickest? Yes. Yeah. Choose the thickest septal measurement. Yeah, that's what we've been using we've been reporting the thickest because you're going to have the least variability with that. Okay. So I'm looking at the time and just mentioning that these are new and not part of the program, but just wanted to mention the guidelines. So the ESC guidelines mention beta blockers, calcium channel blockers, and then they put mavacamten on sort of the line with disopyramide. We don't use any disopyramide. We used beta blockers or calcium channel blockers. I find that they're not very helpful. So usually most of my patients are on a bit of beta blocker. If they haven't tolerated, they're on mavacamten. They can be on both or one or the other. I might titrate off the beta blocker and see how they're doing just on the mavacamten. What's interesting is that these newer guidelines from AHA, they're putting the myosin inhibitor a little bit higher up. So now it's sort of, right after the beta blocker, calcium channel blocker, it's sort of interpreted as being a little bit higher up there. So it's rather than third on the list, it's becoming more second on the list. So it's interesting how we're getting really good outcomes and benefit from the novel pharmacologic therapy. So I'm going to end there. And I think we can, we don't have to go through. Do you want to go through this or?
I think we only have 30 seconds, so maybe we can
Okay.
entertain one question from the
Yeah.
audience,
Yeah.
and then we can wrap this up. Any questions from the audience? Yeah, I asked mine because mine is the one that I can never figure out. How do you standardize Valsalva maneuver? So it's something that worth actually looking into, trying to figure a way. Because the problem is a lot, we actually diagnose patients as well as use the Valsalva LVOT gradient as our guide, but then we actually never no good ways of standardizing it from one time to the other in the same patients or across patients. So, that's something actually worth looking into.
Mm-hmm. Yeah, there's a lot of areas that are not well standardized. One project area we're looking at is a 6-minute walk test. So the NYHA is being used to decide who gets on therapy. The NYHA is garbage. So between doctor and doctor, same doctor, patient, same patient, it means it's meaningless, but we're prescribing medication based on NYHA. And here we've shown that the NYHA, so this is your distance, 1, 2, 3, 4, and it doesn't really correlate with that. So what we're doing is we're asking physicians to come up with an NYHA. Then we do the 6-minute walk test, which is more standardized, and then we check to see if they would revise their NYHA. And what we're finding is that a lot of patients are getting reclassified, mostly in the NYHA 1 category. So those patients are being up-classified because what patients are doing is they're not necessarily reporting their symptoms, they're minimizing what they have to do, and so it's hidden. They're just changing their life to do less because of symptoms, and so they're coming out as NYHA 1. And so, 58% of people that are NYHA 1, this is a still, ongoing study, were classified as higher based on their 6-minute walk test. So we're hoping to expand this. Maybe we could do something like this in Toronto as well. And then finally, we're creating a website to provide more resources. So all of this stuff will be on a website. We want cases. So if you guys have good HOCM cases, even if the sonographers want to have some nice cases up to share, we can put them up onto this website. And then I'm hoping Chi-Ming can help us get this connected to the Canadian Society of Echo website. So lots happening. Thank you.